And we have included a live demonstration. So before we get started, we make sure that we have the following on hand. Second, okay, so the first being the video with the breathing maneuver. Our first introduction and explanation of the maneuvers takes place outside of the scanner room, where the patients watch the video, they practice with us and have enough time to ask questions. The second, we make sure that the pre-recorded voice commands are connected to an audio source. Next, we make sure that the heart rate sensor, respiratory monitor, and timer are accessible and ready for use. And lastly, we make certain that the following points are well documented. And these points are the baseline heart rate, the maximum heart rate during hyperventilation, the respiratory rate during hyperventilation, and the maximum breath hold of the patient or participant. This data will be used later during image analysis.
How to prepare the patient? It is very important to explain to the patient what is the breathing maneuver. It is a 4-minute sequence where the 2 first minutes, the patient breathes normally. Then we instruct the patient to breathe in and out deeply and rapidly in sync with the metronome for 1 minute. And finally, it's a breath hold. We use a video to show this technique. At first, the patient is breathing with his chest.
Breathe more deeply.
It is corrected. Notice how he's now breathing with his abdomen.
How to place the leads. On our GE Premier scanner, we use vector gating, and this is how we place the leads. Different vendors have different lead placement techniques. It is very important to tape the leads to the skin to ensure proper lead contact with the skin and ultimately accurate and constant ECG readings. So once the patient is in the room and on the table, and once the bellow is in place, and prior to entering the bore, we have the patient practice the hyperventilation, just a couple of breath holds, a couple of breaths, so that we may verify if they have grasped the technique properly. And this is how they practice.
Okay, sir. Now let's practice your breathing maneuvers.
Sorry. Let me do that again.
Okay, sir. Now let's practice your breathing maneuvers. So just follow the beat, please. That's perfect.
So we verify their breathing pattern by using the in-room display monitor that you see in the upper right-hand corner of your page.
Now we will show you a live demonstration. So please pin my video, Sylvie Gelineau.
So, and if I may interject, so now this is an opportunity for everybody. It's actually really interesting. I'll definitely join. So when you hear the breathing commands for the participant in the scanner, just please try that yourself. Deep breaths, 1 second in, 1 second out. Can be through the nose, but if it's too tough for the nose, then through the mouth. And then for those who have never done that before, for some people the hyperventilation feels a little bit uncomfortable. There may be some tingling, even some dizziness or so. But I can tell you, once you start holding your breath, it all disappears and actually feels even better than before. So it's nothing really. There's no risk associated with that with a 1 minute hyperventilation. So it's all good. So I invite everybody to then join. So back to you, Maggie and Sylvie. Sorry.
Thank you. On which one? This one? Hang on a second. Yeah, there we go. So can everybody see the screen?
No.
Not yet.
Your cameras are not on.
We have to turn the camera.
Turn the camera on.
You guys have to pin Sylvie Gelineau. It's her face. Here. Pin this Sylvie Gelineau to your screen.
Yeah, we can see.
Okay, so you can all see the screen now, yes?
Oh, I see. We want to pin. I see.
Scanner.
Yeah, I can see it. Yeah. So if we show them again, so everybody doing the right hand. Yeah.
I
Oh,
don't.
perfect. Oh,
So
there.
is
Yeah,
it-
there.
Does everybody see the screen? I don't.
You have to. So under
Here, it should be
Sylvie.
pinned now. I just
Okay,
pinned
okay,
it.
I get that, yeah. So
Yeah. No, but each person has to pin them on their own screen.
Yes, that's it.
Yeah. So everybody who's out there, you see everyone's images all together, but under Sylvie and Maggie on the top right-hand corner, if you click that button, you
not
can.
necessarily top right-hand corner. Some may flip through several pages here.
Under Sylvie Gelineau.
Under Sylvie Gelineau, not Maggie and Sylvie, Sylvie Gelineau.
The video is on with the monitor
Oh,
showing.
yeah, it's actually the screen.
Yes. Yeah.
yeah,
Sylvie. So
okay.
Sylvie Gelineau.
It's the blue screen, yeah.
Yeah,
That-
right
now we're
click.
live, yeah.
Can everybody give me a thumbs up if they were able to do that properly?
Yeah.
Great.
Yes, excellent, excellent. Okay. All right, and we're zoomed in, so we're ready to begin. So we're ready for the OS Scout. Okay, and so we use end-systolic phase to plan the two slices. So Sylvie's going through the cardiac cycle, as you can see. So she's going to settle in on the end-systolic phase. And so the first slice is placed at the base, and the second at the mid-ventricular level, where there is a lot of myocardium. Also at this level, we are avoiding flow artifacts from the valves. So once again, once your slices are there and you're going through your cardiac cycle, if you feel that your basal slice is a bit too close to the valves, just move it down a little. It is still considered a basal slice. It's just the let's say mid-basal slice. Once you're happy with that positioning, verify your shim, and proper shim placement is very important. So it is not necessary to cover the whole heart. Just focus on the two slices, and that would be sufficient. So now she will start the sequence. This is a breath hold sequence that will be compared to the post-hyperventilation images. So we're just doing that right now. So what you see here is now the scout is done. And we verify if there are any artifacts.
Breathe in. Breathe out. Hold your breath. Relax.
There we go. Okay, so the scout is done and we verified for artifacts. The most common area for artifacts is at the infralateral portion, right over here, of the myocardium, where we sometimes see a BSSFP susceptibility artifact due to its proximity to the stomach. And this is especially on a 3T. If no artifacts are seen, and Sylvie has gone through the images, there's no artifacts are seen. So basically you just copy the same lines and shim as in your scout, and you are ready for the OS continuous acquisition. So we are just prepping for that. So right before we begin, Sylvie will speak to the patient again and just inform them and remind them that we are doing the breathing maneuver. And as Dr. Friedrich had just mentioned not too long ago, if anybody is willing to try the breathing maneuvers, please do so. Just follow the voice commands that our participant is also following. Vas-y, go ahead, Sylvie.
Sometimes you have a delay because the SAR is higher.
Oh, okay.
So you can see here that I have to wait 4 seconds to start the sequence. Okay, sir, now we're ready to do the breathing maneuver. Just a small reminder, at first, you're gonna breathe normally. Then you follow the metronome in and out deeply and rapidly. And the last part is a breath hold. I want to make sure that you hear it properly.
Yeah, and for everybody, when you hear that beep, that's each of these beeps is either inspiration or expiration. So the first beep you hear is inspiration, the second is expiration, and then continue. With every beep, you do either inspiration or expiration. And for those who still don't see the screen, you have to find within the participants' views within the videos, you have to find the blue screen that is called Sylvie Gelineau. And if you use the pin function of Zoom, you can actually get it full screen.
Did you hear the beep, sir? Very good. So just follow the instruction.
Please breathe normally.
Okay, so pre-recorded voice commands are used since it is easier for the patients to hear and are therefore better for consistency, compliance, and reproducibility. During the 2 minutes of free breathing, you will see blurry images, which is expected. During the hyperventilation, it will become more apparent. The post-processing and motion correction are done afterwards. We will now do a duplicate and setup of the sequence so that we may show you an important parameter to consider. When planning the continuous acquisition, the total number of phases is very important because it determines the acquisition time, which is affected by the heart rate. And just as a reminder, this is a cardiac gated sequence. So give yourselves ample time to compensate for the varying heart rates. Here at our site, we aim to have an acquisition time of over 5 minutes. So watch what happens when we decrease the total number of phases. We were at 27, which gave us ample acquisition time. And if we decrease, note how much the time has also decreased. I will now draw your attention to the heart rate. This patient has a resting heart rate of 68, 67, around 70. During the hyperventilation, it is expected that the heart rate response will increase by at least 20 for the healthy participants. Also notice the respiratory trace and the respiratory rate. Right now, he is breathing at a rate of 12. And look at the respiratory trace. It is a very relaxed, normal breathing.
Start breathing with the beeps.
So during the hyperventilation, verify that the amplitude of the respiratory trace, there we go. See, notice how it's deep breathing. This will indicate if the patient is breathing deeply with his abdomen.
Continue, Glenn. In and out deeply.
Okay, and also make sure that the respiratory rate is reaching 30.
Follow the beat.
Okay, and if either is not done properly, guide the patient through the intercom. Tell him belly breathing, belly breathing. That's it. This patient is breathing. That's it. And the blurry images, there we go. That is very normal.
Breathe in, breathe out, hold your breath.
Okay, this is where you use the timer and start it as soon as the patient holds their breath. Okay, the post-hyperventilation breath hold should be at least 40 seconds to guarantee 3 full cardiac cycles for analysis. If the patient's heart rate is high, you will obtain 3 full cardiac cycles sooner. You will now notice how the images are sharper.
Still hold your breath if possible for those who participate, sorry.
Yeah, and you will notice how the images are now sharper because the patient is holding his breath. And this patient is well on his way of holding his breath for a minute. Oh, there you go. Spoke too soon. There you go. He reached 48 seconds. All right. The OS is now done, and we have shown you these few simple steps that we use on a daily basis to run the breathing maneuvers. Before we continue and go back to the PowerPoint, if anyone has any questions with regards to the setup or any of the parameters on the screen right now, please unmute yourselves and go ahead and ask your questions.
It would also be interesting for those who participate in the breathing maneuvers or in the hyperventilation, whether you sensed anything.
I definitely felt lightheaded, maybe, yeah. So, but briefly.
Yeah.
Okay. If there are no questions, we will direct you back to the PowerPoint. Share screen.
And we can all remove the pin then, right?
Yeah.
Okay, so everybody please remove the pin. Martin Yannick said that actually the hyperventilation felt comfortable for him.
Good. Let me click on this.
How to ensure success. Make sure your patient understands and can do it correctly. Practice outside the table, outside the scanner, inside the scanner with the bellows, and just before you start your sequence.
Next, proper lead placement. We cannot stress enough the importance of taping those leads. This is especially critical if the patient's skin is clammy or if they perspire easily. With the poor setup, you risk not having a proper ECG reading, which may cause your sequence to abort.
Proper number of phases. Make sure the number of phases is sufficient. If the breathing maneuver is not successful, wait 3 minutes. Give the heart rate time to return to the resting state. Repeat the OS scout and repeat the OS continuous acquisition. Thank you for your attention.
Thank you very much. Also to Katarina Ayer for being our official videographer and for her invaluable assistance with this presentation. Thank you, everyone.
Thank you.
Amazing job, guys. Thank you so much for doing that live demonstration for us. Does anyone in the crowd have any questions?
Yeah, there is a question here from Lena Robinson, the Mala. She asked, the breath hold is for 1 minute?
It's a maximum breath hold of 1 minute, but we require at least 40 seconds, 30 to 40 seconds, as long as you have 3 full cardiac cycles. So if the patient's heart rate is very high, they will reach that 3 full cardiac cycles sooner. But if they, if not, then just, at least 40 seconds would be sufficient.
Beautiful. 1976 Lamborghini Countach.
Oh, someone's talking about a car. So there's a comment here in the chat about free divers. Matthias has done a study using free divers, so I was wondering if you wanted to talk about it. I will anecdotally say that when I had to do all the analysis manually, and you will all see very soon about the new automated analysis, when we'd put Matthias in the scanner, he would hold his breath for like 3 or 4 minutes. And for me doing manual analysis, it was a complete nightmare. So I'd stop the scan. I couldn't. And he's so competitive with himself that he'd get better each and every time. So the minimum required breath hold for us is 30 seconds, but some people can far surpass that. So Matthias, I don't know if you want to comment on the free divers.
There is certainly, we have also done some studies where we repeated these breathing maneuvers, and that's why what Sylvie had said, to make sure that the patients had done that before, ideally also before the scan, outside the scanner room, that they practice it once. So you get better every time with holding the breath. But as everybody said before, it's for the diagnostic purposes, it's actually not that important, because as we've seen yesterday, we reach a plateau after about, with the vascular response, about 20-30 seconds into the breath hold. So everything thereafter is basically just for your pleasure. So and I can say these breathing maneuvers, for those who are interested in that, just send me an email. There's a lot of interesting research out there, and also a lot on the internet, basically with pseudo-scientific backgrounds. Certainly the breathing maneuver with hyperventilation and breath hold, what it means is basically it's like gymnastics for your blood vessels. And it's like what you basically do with a cup of coffee is you reduce blood supply to your brain for a while. Many people say that the breathing maneuvers can actually have a similar effect. And I can tell you very, very openly that, for example, this morning I woke up with a slight headache because yesterday I had to have a glass of wine, which to me sometimes causes headaches. And I know that I can get this slight headache easily away with 2 of these breathing maneuvers, probably related to the vascular tone that basically then can be normalized by that. So there's lots of literature out there, also scientific literature, how brain and to some extent the heart perfusion are altered. But the bottom line is, Lizzie, to your question, yes, it gets better with every time, and it's not necessarily a competitive thing. It's more learning to really relax during the breath hold, so that to breathe out and do this without any effort, and then over a while you get way more tolerant to the higher CO2 levels, and nobody should be concerned. Nobody will make it to a point where the oxygen level actually dropped to a concerning level. So that's not a concern. This procedure is really very safe. There are only, if you hyperventilate for 5, 10, or 30 minutes, there may be for people who are prone to coronary vascular spasms, theoretically, there's an increased risk. We have seen in all those about 600-700 cases, not a single one where any of that happened. Back to you.
Thanks, Matthias. And we have a comment in the audience from Martin Yannick, who has experience with this. It's great demonstration, such an easy and safe procedure. And thank you, Sylvie and Maggie, for that.
Yeah, to address another question, asking if this was a 1 or 2 slice acquisition, it's 2 slices. We usually do a between basal and mid slice and a mid apical slice. We try and really avoid being too apical because since the calculations are in the myocardium, if you're too apical, you just don't have enough pixels. So we try and be pretty careful with that, but it's a 2 slice acquisition overall.
And regarding the slices that we saw, so when you look at the slice position, the basal slice probably could have been even more, a little bit more towards the basal. So as Liz said, ideally, if we have currently 2 slices, then the basal of those 2 would be between the basal and the mid third of the myocardium, and the more apical one would be between the mid and apical, just avoiding the apex and the valve. That's currently, and this is of course a limitation. Ideally, we would have more data, but on the other hand, we know also from perfusion studies that the base and the apex often are problems because of flow artifacts and partial volume effects, especially in the more apical parts, where then the myocardium is not perpendicular to the slice, and then we have contamination from blood.
And I just want to reiterate, if the breath hold isn't long enough or you're getting artifacts throughout the acquisition, we wait 3 minutes and then run the breathing maneuver again. And getting those clean images, enough of a breath hold is critical. So we can run it again, we just wait the 3 minutes. Does anyone else have any questions?
Do you want to comment on caffeine and what else we do to prepare for perfusion scans?
I can comment on it. Do the techs want to comment on it, or are they're over talking and they did their job? No, they're gone.
You're muted. You're muted. You're muted, Maggie.
Okay, sorry about that. when the patients are asked to come, they are asked to withhold from any coffee, tea, chocolate, anything caffeinated for 12 hours prior to their exam. So, and in all honesty, from the patients, I think that is the hardest part of doing the exam, is not actually the hyperventilation, but the actual fact that they cannot have their little cup of joe in the morning. So yeah, so that is, so 12 hours is our go-to request for them to withhold.
This is, of course, just we do that just to make sure. We have not systematically assessed that. It would be interesting to see, although we have a little bit of experience. I don't know, Kate or Maya, whether you want to chime in here. We had, of course, some people who couldn't help themselves and had some coffee before, and then some of them we did it anyways. So do you want to comment on this experience?
Sure, I can comment. So I had patients who had a perfusion deficit in MRI, and when I looked at their heart response, because they had taken a coffee also in the morning, it's still like their heart response was blunted. And I had 5 patients that took coffee in the morning, and it seemed that like the heart response was not affected by coffee. So I think it would be interesting. So in the next stages of actually my study, to look at also the impact of coffee on the heart response breathing maneuver and see if it really affects or not. Yeah. Thanks.
I just wanted to add also, it is a fairly easy a sequence to follow through on. And, you know, if the patients are overthinking it, then, you know, we just tell them, like, just pretend you're running. Basically, you're running a marathon, and it's just, you know, deep in and out. You know, when they're just breathing at rest, you know, we just say that, you know, you see like on the respiratory trace, you see little moguls. When they're running the marathon and doing the hyperventilations, we always tell them we want to see the mountains and the valleys. So, and obviously always with the abdominal breathing. So once they get that concept and you know, and try to do the deep breathing with the mountains and the valleys, then it actually just falls into place afterwards. So it is pretty successful, pretty easy for them.
And for those who came in late, just to reiterate that the sequence basically is running all the time. So there is no need to start and stop the sequence. You start it, the participant is breathing regularly, then does the hyperventilation with the beeps, and then holds their breath, and that's it. So on the scanner, not much is happening, right? Other than you watch the respiratory rate and the images, yeah.
That's it, and we guide them if they're trying to be, you know, too fast or too slow with the beeps, and if they're good, you let them be. And then some patients want to know when they start their breath hold, because they want to make sure that they attain the minimal 40 seconds. So some of them say, just tell me when we reach 40 seconds. And some of them want to know every 10 seconds, you know, where they're at, so that at 40 seconds, if they still have it in them to continue, then by all means, they continue holding and they try to break their own records, like you, Dr. Friedrich. And if not, then if they can't hold it any longer, then they know they've succeeded, because we have the 3 full cardiac cycles, and at 40 seconds, then they start to breathe normally. So you can use either, depending on each patient. So you just, you know, cater and go with each patient, their needs.
Unless 4 minutes is an absolute exaggeration. I can't do 4 minutes after. And I'm not a free diver. 3 minutes is okay, but no false information here.
Okay, does anyone else have any questions? Observations, remarks?
Nope, doesn't look like it.
Okay, fantastic. Thank you so much, Maggie, Sylvie, Katerina, our healthy volunteer in the scanner. That was fantastic. And I hope everyone saw how easy and doable this kind of acquisition is. I think sometimes when we talk about OS CMR, we talk about the breathing maneuvers, people get really nervous about what does it mean? How do we do it? How difficult is it? So I really hope that we were able to show that it's quite simple and just with some training. And the key thing is being able to go over the breathing maneuver with the participants outside of the scanner so they really get the hang of it. Because as Matthias said, the more you do it, the longer you can do it and the more comfortable you are with it. So, all right, moving on. So up next, our next speaker needs absolutely no introduction. Mitchel Benovoy, as you heard yesterday, is the VP Innovation at Circle, and he is one of our key collaborators and kind of the brains behind the new tissue oxygenation module, or TOM, and he's going to give us a walkthrough and demonstration of the module. So if you guys have questions along the way, put it in the chat box. We'll have a discussion at the end. We really want this to be interactive and for you guys to have an opportunity to see what we're working with in terms of analysis. So Mitchel.
Thank you, Liz, and good morning, everybody. So this is a real live very stressful demo of the prototype module. Big emphasis on prototype here. I have been praying for the last 30 minutes to the demo gods that this will go smoothly. Without further ado, let's get going here. So I'm in CVI 42 here. This is our prototype build with the module. And here you see the patient list as usual. I'm just going to select this patient here. It's the standard CVI 42 interface, except we have this OxySense module here. This is a working title, probably change it to something else, but nonetheless, this is the module that is used for analyzing the OS data. And from here, it is pretty simple. You select your continuous acquisition, which is the second one in this case. I'll double click on it, and you're presented with this pop-up to enter the start and end phases of each of the breathing states. You can navigate through here to see when the free breathing stops and when hyperventilation starts. So this is obviously a hyperventilation here. And then if you keep going, you'll see the breath hold here. So you can use this little navigator to kind of pinpoint where the breathing states start and stop, and just enter the information. So for this patient, I just took note of them beforehand. Okay, and when you click OK, the processing will start. Now this takes, for now, several minutes. I think about six and a half minutes. There's a significant amount of processing going on. The short axis contouring is going through every phase of the series. And then that will be followed by motion correction, signal to noise ratio boosting, and co-registration. So each breathing state is co-registered to one another. And this is for some of the exploratory biomarkers that we're looking at. For example, if you want to compare the post-hyperventilation breath hold with your free breathing phase to phase, we're registering those images together. You can think of maybe computing a pseudo NPR ratio of like kind of your stress post hyperventilation compared to free breathing or resting state. So there's a lot of computations going on. There's literally thousands of image registration steps that are going on in the background. So this takes a little while, and I would certainly welcome some discussion while this is going to fill in the blanks.
Yeah, no, I wanted to just highlight what you said. Sort of this version now needs a manual input of the end of the hyperventilation, etc. This is very important in the future. This hopefully will be automated, hopefully sometime soon. But this has to, in the initial, let's say, in the first studies where we did that manually, this was always a very important step. Because if you do not correctly identify the stages, of course, your values are not necessarily correct, and that's why this is quite important. This is one thing I wanted to stress. Another one, Mitchell, to you, when the contouring, so we of course have to be quite concerned about partial volume effects with the blood. So a question to you is, does this map that we basically, that the tool generates here, do these maps actually need the contouring, or is this a map that it would be generated for the entire image and the contours just select those that are visualized on the screen?
For now, we're just concentrating on the myocardial pixels. So the contouring are fairly important. And you bring up a very good point of the partial voluming effects. Those become kind of critical when you're looking at a polar map representation. So when you're averaging a big amount of pixels together, if you have just a few of them that are inside of the blood pool, and your whole AHA sector can be artificially enhanced or amplified. Those are for the so it's very important for the polar map values that your contouring is good and excludes either blood pool or the lungs. But for the pixel-wise maps, it's not so important. It's not so critical because you will see on pixel-wise level, around the blood pool, if there are some partial volume effects, you'll see that they're bright, but it won't affect the neighboring pixels. So it's just a concern there for the AHA representations. And it's not in this prototype, but in the next build, we will have an offset function to make sure you're far away from the blood pool or from the lungs. That's coming up in the next iteration.
Thanks, Mitchell. There's a comment from the audience, if you don't mind answering, from Calder Shigren. Are these calculations happening on the server side, or what kind of hardware is needed for post-processing calculations?
This is all on my standalone workstation. Server-side processing is definitely something that's on our roadmap. You can imagine that the series, once it reaches the server, we have an automated processing that would be triggered. So by the time you're sitting down for a read, all of this analysis would already be done. It is computationally heavy. These processing algorithms are fairly sophisticated and do scale very favorably with more contemporary hardware. But on a server, you usually have a fairly strong machine there, so that should be fine for most cases.
Okay, that's great. So it looks like for this prototype, eventually we're just waiting on this final baseline breath hold. Does anybody else have any questions in the audience or any comments what they see so far?
So Mitchell, when I saw the first, and then people may have the same question here, during hyperventilation, the images of course look, to say the least, horrible. And I initially thought, okay, that doesn't make sense at all to even look at these images, let alone evaluate them. So can you comment on what you do with these and your level of confidence that the values generated from these images are meaningful?
For this prototype version, I wouldn't look at the hyperventilation images. We are working on a very robust deep learning based motion artifact removal system that is in development. It is quite impressive. Actually, maybe I'll pull it up after the processing is done. Well, I'll show you some examples of what we can do to clean up severely affected breathing cases. But for now, I wouldn't look at the hyperventilation data, at least not in this build. But it is on our pipeline to do retrospective correction of motion artifacts. And if we have the case-based data, then we can create an inline system to clean this up too.
So, but what you're saying is the result of the hyperventilation, which is the end of the hyperventilation, as then still present in terms of the metabolic state, still present during the initial phase of the breath hold. That is, of course, then already reliable. And what about the free breathing? Do you think that we're comfortable enough to use these values?
In some cases, yes. I don't think this particular data set would be good. You'll see that they're severely distorted. But in some acquisitions, our current artifact removal system is good enough to clean those up. But it seems to be kind of patient specific and acquisition specific. However, that same neural network to clean up the hyperventilation data sets will also be applied to the free breathing acquisitions.
So then the most reliable portion is indeed the post-hyperventilation breath.
For this prototype, we were focusing a lot on kind of the most well-known breathing state and exploring the biomarker landscape from that post-hyperventilation breath hold as a first phase of R&D for it.
Okay. Yeah.
A question to Mitchel. And so in order to run the TOM, then the user side will need to have license to Circle. Is that correct?
Yeah, but we have probably the most generous research, collaborative frameworks to work with, where if so we have a process where anybody is welcome to submit a research project to us, and it's evaluated by our scientific committee. And if we see some strong benefit to the society, to clinical research, then we usually send over free licenses for the duration of the research projects. So that's certainly something we would welcome for this work. It is within Circle a very important strategic initiative, not only for clinical research, but down the line. We strongly believe this will be a very potent diagnostic tool. So we're glad to support the pioneering work that is going on right now.
Yeah, and I see Zilka representing from Circle is here, and if she could provide an email address, or for other researchers, our collaborators, international collaborators, if they're interested in the group chat, how could they reach out to initiate getting one of these complementary research licenses? So if that that information can be made available at any time. it'd be great. There we go. So thank you so much, Silka. So for all of our international collaborators out there, like Mitchell mentioned, not only about Be More OSCMR, but feel free to send your research proposals and requests to Silka Friedrich, representing Circle CVI here, and we can initiate that collaboration so that you can have this prototype module too and play around with it on your end as well. Silka, would you like to say anything?
No, just that we welcome every request, and yeah, so just send me an email and we will be in contact.
Great, thank you. Okay, Mitchell, back to you.
All right, well, it looks like the processing was done, so that wasn't too bad. I have I think a 3-year-old desktop computer here, so that not too bad. Considering that and analyzing every phase of a study would take, correct me if I'm wrong, Liz, about a day. I think this wasn't too bad in comparison. So here we are in the results panel of the module. So you have the breathing states here shown. Free breathing up here, hyperventilation, post-hyperventilation breath hold, and if you would have a baseline breath hold, again, that just in case 15-second acquisition before anything, before the continuous acquisition, you could see your results here. So there are different ways of visualizing the biomarkers. First and foremost, my favorite is certainly the pixel maps here, which are dynamic. So you can see what's going on through the cardiac cycle. You see the polar map is also updates phase to phase. You can look at a single intensity, a sector-wise temporal curve. So here you can select your sectors that you want to look at all of them at the same time. So these are standard AHA sectors. We also have a higher resolution polar map. So this is a 100 segment, perhaps a little more robust to partial volume effects. But for me, the nicest one and the most, I think, interesting one is the dynamic polar maps, and these are very cool. You can select down here which biomarker you want to look at. So let's select our pseudo SpO2 biomarker. Down here are the lookup tables. You can customize your lookup table. You can add new ones. Whatever suits your fancy. Yeah, that's pretty much it. So this is the way we can analyze the results. You can add the biomarkers to the scientific reports and easily bring those into Excel or SPSS or whatever you want to use for your statistical analysis. If you see that the contours are not quite right, you can just click on one and edit them manually. For example, if you want to push the contours out from the blood pool manually, you can do that, although that is coming up automatically soon. But you really have full control of the contouring, of the biomarkers you want to report on, and the way you want to visualize them. And that's pretty much it. That's kind of the high-level overview of the module. It's fairly simple in its interaction, but very complicated with what's going on behind the scenes here.
That's so great, Mitchell. Before I ask my question, does anybody else, if you're raising your hand or putting in the chat box, they have any questions at all? Okay, so Jill Wares asks, with only 2 slices, do you worry you might miss more apical regions of ischemia? I can address that question too, Mitchell. Or
Yeah, please do.
yeah, so we certainly do, but I mean, that's always a concern. You know, we're not capturing the entire LV cavity, both, you know, basal down to the apex. But the area of that apical, if there is to be ischemia, is likely a small proportion of the impact of it. And so recognizing that we want to get, like Liz Hillier mentioned before, the highest number of pixels of highest information. And so even if we were to capture that apical, could we even trust that information? So after doing all of the experimental analysis, that basal mid and mid apical are likely the highest bang for our buck. And ischemia isn't, you know, if there is going to be a significant amount of ischemia or microvascular dysfunction or reduced or blunted oxygenation, it's likely not going to be just in that apical region. It's going to be some sort of coronary territory or heterogeneous throughout the myocardium. That's a good question. Okay, and a question to Mitchell, like what is the potential of, say we have one of our collaborators, they came up with another biomarker or that they want to add, and how easy or difficult is it to include that into the module, and is there a room for it to be improved and upgraded?
Absolutely. We want this to be a very open effort, a really collaborative effort. If you think of a cool new biomarker, by all means, let us know. We'll evaluate it here. We'll do a quick prototype of it, and if we find that it's valuable, certainly consider including it.
Yeah, so as I mentioned right at the beginning today, if I may interject here for a second, ideally we would get some of you or those of you who are interested in becoming a member of an early adopters, an expert group together, so that we can together discuss some of these biomarkers and support the scientific exploration of that with the support of Circle. We have a similar initiative regarding quantitative perfusion with which we started a while ago with Circle and Zirke's help. Mitchell, you and I are part of weekly or bi-weekly meetings with the centers, including Stanford, Chicago, and some other sites in Italy and in the US and Canada, where we look at quantitative perfusion validation. And so something like that, I think, would be great. So those of you who are interested in becoming a part of an early adopter expert team, please let us know, and we'd be happy to help everybody to get the right tools, and also help with the designing all these studies, and then basically sharing the workload of doing the necessary clinical validation studies in certain patient groups and other subpopulations.
Thanks, Matthias. And there's one question from ThinkPad. Sorry to Mitchell. So sorry, I might miss the key information, but how does the OxySense module or the TOM module work based on specific dye or other injective drugs?
So that's the beauty of this. This is needle-free acquisitions. The only stimuli is really the breathing maneuvers. And so this is why we have the module set up with these different breathing maneuver states that you can look at. But there's absolutely no contrast, no pharmaceutical agents here. It's purely driven by simple breathing.
Oh, great. And the question from Ed Diabella, does the software also show time curves post hyperventilation, like in many of the papers?
Yeah, I think Elizabeth is going to be showing that very carefully right after me. So stay tuned for that.
Just while I'm loading up a case here, I wonder if, given the previous question, Matthias could just recap, and I know that he probably doesn't have this loaded, but the figure of the signal intensity curve and how that changes with the vasoconstriction and vasodilation, because I think that maybe that's a point that's being missed in how we calculate our parameters. Just based on that question, Matthias, I wonder if you.
Give me a few seconds. I will show that.
Yeah. And I think it's a good question. I know it took me, I've been here for 5.5 years, so 5 years to fully understand what we're doing here computationally. So I think that to get this all in 4 hours is pretty complex. But I know that once I saw the module and what we were doing, going back, thinking about the physiology of it more or less was a lot more interesting. So here we go.
I think that's what you refer to. So
yeah.
For that question, so again, this is what is happening on a vascular level. The hyperventilation leads to a vasoconstriction because of a drop in carbon dioxide in the blood. And this drop of blood flow happens actually in the heart and in the brain. This has been validated by multiple studies in experimental protocols in animals and with different methods like cerebrovascular Doppler and such. And we have also had our share of validation studies in larger animals with the careful measurement of coronary blood flow during all these maneuvers. And once the hyperventilation finishes and a breath hold is executed, then you have a recovery of that, and then even a slight overshoot. So you have a pronounced vasodilation, which is when you perform this breathing maneuver. This is what leads to that subjective well-being. So the patient initially with the hyperventilation, some feel as Judy feels some dizziness, and then others feel tingling, or some general discomfort. We had even, I think, a few who reported some headache, but all that disappears within seconds, and you reach that plateau during vasodilation after, as I said, 15 to 30 seconds. And this is all there is. There is no contrast agent, nothing else is required. Just this breathing maneuver is enough of a vasoactive stimulus that we can detect that it's actually, from all what we know, it's at least as strong, if not stronger, than what you can achieve with IV adenosine. Even intracoronary adenosine, at least in a pig model, was not as strong as this stimulus. That's what also, and sorry for digressing for 10 seconds, that's what I also think is a significant confounder of our MR studies. So if you do a perfusion scan and you do not hyperventilate in your breath hold, you have vasodilation during that breath hold. It's not as strong as the Chinese data from a few months ago have shown, the paper by Shi et al. in JMRI. It's not as strong, but it's still there. And depending on the length of that breath hold and when you acquire those images, or if you do this free breathing, I think this may actually lead to different results of the perfusion scans, the first pass perfusion scans. So this is maybe a not insignificant confounder, and you can of course control for all of that. In fact, get rid of that confounder by using just a breathing protocol as we have here, where you control exactly that very important factor in the vascular tone.
Thanks so much, Matthias. And again, we're reiterating that we're moving away from any injective drugs, a needle-free approach, as one of the papers that Matthias has showcased yesterday too. Okay, thank you so much, Mitchel, for showcasing that normal case of a normal patient. And now we have Liz.
Sorry, Judy, I just wanted.
Oh, yeah, excellent.
I promised this while I was processing. Yeah. This is our deep learning based motion artifact removal system. So here you have a high grade contamination, which is what you would see in a ventilation acquisition. And this is the result through our neural network here. So the foundational architecture is completed, but what we're carefully analyzing now is whether the neural network correction is washing out or distorting in any way the bold signal, which is extremely subtle. So this is where we are now. We can get excellent, as you can see here, excellent structural or anatomical cleanup. But we just want to make sure that the signal intensities, the amplitudes, the pixels are not being artificially biased or skewed by the neural network. So it's a work in progress that we're pretty excited to keep working.
That was great, Mitchell. And again, back to the collaboration, reaching out to Silke Friedrich, because the more research we have internationally working on this, the better we have understanding that deep learning process and how we can improve this prototype. So another question from ThinkPad. So such hyperventilation and breath hold action could be used to replace the intracoronary adenosine injection to evaluate the myocardial microcirculation. Yes, so that's exactly the point. I'm going to show a couple of slides after this too, kind of what we're talking about, that microvasculature, and Liz Hillier later on will also showcase another example of what we mean by assessing this microcirculation. So we will kind of reiterate that point that yes, this hyperventilation, that breath hold, can induce a vasomotor response. And the whole entire goal is to replace intracoronary adenosine injection, which we have shown already. I mean, in the early after my research data, which was all about adenosine, but after that we moved on from no adenosine. Okay, more questions coming out. Norliza Othman. Theoretically, the motion correction can be done in scanning console, but this one is done by the CVI software. And maybe questions from Mitchell.
The type of motion correction that we're applying here cannot be done in the console. This is, when we're talking about co-registration between the breathing states, for example, or the artifact removal, that's certainly not something that is done on the console for now.
No, but I think it was a question. Can be done, but this one is done by the CVI software.
Yes.
Yes.
Yes, it's all within the CVI software.
Yeah.
We have another question. Can this correction software be used in other areas of the body, example, abdomen?
Yeah, potentially, yes. And that's actually how we're designing our neural networks, is to be anatomy agnostic. The heart it's actually easier in other parts of the body that are somewhat more stable. The heart is by far the most dynamic area. So we think that if we nail it in the heart, the rest of the body will be a walk in the park, so to speak.
Sorry, I just want not to put Constance Capozzi on the spot, but I may have missed a question from him. If you don't mind, is unmuting and you can ask the question live again. Oh, Constance. Oh no. Okay, that's okay. And so Matthias also just put in the chat to everyone, for everybody interested in becoming a member of the Be More Expert group, as you referred to before, please do email him at his direct email here. All the information contacts that we're putting out here will also be sent out to the members after the symposium, in case you didn't have a chance to look at the group chat.
And this is really meant to just support these research initiatives. It's not about somehow getting publications to Montreal or whatever. No, it's really supporting the field, that because nobody here can do the work alone, and for all those who are interested in this is in exploring these new biomarkers in various populations, they would be welcome. And of course, as soon as there is a prototype, an advanced prototype out there that we could use for clinical applications in research populations first, then as Mitchell said, then Circle would be happy to help with the research licenses. And then let's hope that there will be FDA certification in the foreseeable future, and then this can be used then also clinically. And I think many centers would be happy to get rid of contrast agents for that purpose and use this quick scan instead. But we first have to go, of course, through the phase of validation altogether here, and have to learn more about it.
Okay, excellent. And so thank you so much, Mitchell. Thank you for the great discussion so far. So now Liz is going to be showcasing a good comparator to this normal healthy volunteer that we just had. And she's going to go through the TOM module on a patient who has a coronary epicardial coronary artery disease.
Yeah, thank you, Judy. It's just in the last stages of loading up on my other computer here. So I wonder at this point, does anyone have any thoughts on, new biomarkers we could use or project ideas just to get things off the ground, or any thoughts out there? We have 70 participants. Someone's got to have a thought here.
And I'd invite people here to really think outside the box and really appreciate that we can do like combination biomarkers where because we have all this, for example, the functional information at the same time as the single intensity information. Think of with looking at, for example, biomarkers and diastole versus end systole, or quarter cycle, or combining strain with the both single intensities. Look at the kinetics of the single intensity changes. These are all available now because of this really high temporal analysis that we can do with this module. So really think outside the box for this one. Think outside of static biomarkers.
We have a comment from ThinkPad. What is curious to see whether such response to hyperventilation can be changed in the setting of patients with heart failure. And this is definitely an area of ongoing research that we do have with collaborators both in Canada and ourselves and data, and with Katie Fisher from Bern as well, is to understand this complex heterogeneity. So this complex heterogeneous pattern of biomarkers that we're gathering from heart failure patients, because certainly they, depending on the etiology of their heart failure, it could be microvascular, it could be ischemic, it could be all of that. We're only touching the very surface of that. So 100% we are testing and evaluating BMOR in the heart failure population of different etiologies. Okay, and so, oh yes, go ahead, Liz.
Okay, I'm just trying to load my thing here. Here we go. All right. I prayed to the same demo gods as Mitchell, so hopefully they bless both of us and not just him, because it's worked really well. So this is a case, as Judy mentioned before, of epicardial coronary artery stenosis. So this is actually a case from our BMOR international trial that's currently going on in worldwide. This patient had an LAD stenosis with an FFR of 0.57, so quite significant. And this is what our results have shown. So this module, as Mitchell has shown already, I have I've run the whole thing. So I included a baseline breath hold, which is actually quite key in our acquisition. And so this frame here, I know it says baseline breath hold. This is, as Mitchell said, this is a prototype. So just where things are fitting in. But this polar map and this, so this polar map and this pixel map are showing our breathing enhanced myocardial oxygenation reserve. So this is the BMOR that you see in all of our publications. This is showing this currently. And so we can scroll through the entire cardiac cycle. My laptop might blow up if it does, but there's contours in every cardiac cycle. There's contours across our acquisition. So this is a 4-minute acquisition, 2 minutes of free breathing, 1 minute hyperventilation, 1 minute of breath hold, and it spits out all of this information. So for us to see this significant of a response, where we see that the RCA territory and some of the LCX, but specifically the LAD territory has quite a reduced response. And so for us, this was fantastic. And this is one of our stronger cases, obviously, because we're showcasing the good stuff. But this is just an example of how the module can work.
There was a question, Liz, from one of our Chinese collaborators. I'm not Chinese, but they had their hand up. Could you have your hand up again and maybe text your question and ask your question?
Or speak aloud.
Yeah, speak loud. They took their hand down, so, or maybe it was by accident
situation.
Okay.
So as
Yeah,
you can see here, I'm scrolling through the entire cardiac cycle. And it's contoured very well. I haven't touched these contours at all. This is fully automated contouring. And you can see that oxygenation deficit is there throughout. This is quite a significant case for sure. And these are both of our slices here. So this is the more basal slice. You can see it going into diastole, coming back into end systole, where we take most of our measurements. Again, moving down to a more mid slice. You can maybe even zoom in a little bit here, so we can really appreciate the full extent of what we're seeing here. So this is quite striking. This made me really happy to see. And then, with our other publications, the circulation research letter where we talk about the regional heterogeneity and ANOCA, those are just different coded biomarkers. So it's just different calculations, but all based off of the same data and just looking at the changes, the dynamic changes in the signal intensity a little bit differently.
And I wonder, Liz, if you can provide some sort of idea about, well, I guess we don't have much severity, but is it the more negative, the percent difference, that's like a more blunted response. And and so the areas of green showing, 55% increased oxygenation from hyperventilation to breath hold is essentially normal myocardium on the polar map. Yeah, okay.
For sure. And I would encourage everybody not to pay attention to the numbers here. Our previously published values won't really line up with this. -17 is very negative for us. And we're coming around, with the different way that we're post-processing this and the different analysis, our numbers will probably change and just shift a little bit. But yes, fundamentally, if you have no change or a negative change, that indicates not healthy myocardium, what kind of disease process that looks like. And then the positive values and the green values here representative is healthy myocardium.
Excellent. We do have a question here too. And so maybe if Meg or Sylvie, who are on the line still, do patients with oxygenation deficit, so presumably some sort of abnormal myocardium, underlying pathology, like coronary disease, ischemia, do they experience difficulty in holding their breath before and after hyperventilation?
Every patient is different.
And so in your experience, which ones tend to have more difficulty?
Well, when we're actually doing the hyperventilation and the breath hold, we won't know just from seeing like some of the images that if they do, well, hang on a second, just repeat the question. Is it ischemia that they're looking at?
So just oxygen deficits, but oxygen deficits can be from a number of causes, but do you find that patients who come in, for an indication like, rule out coronary disease, and then we do the OS CMR on them, do they experience difficulty in holding their breath before or after the hyperventilation? So holding their breath after the hyperventilation.
No, I think the patients that have really problems holding their breath is the patients that have lung issues and not necessarily cardiac issues. Because once after they've done the hyperventilation and they have a good fast enough heart rate, the 30 seconds or even 40 seconds are easily attained. So the only patients really that from the get-go that we have that they have difficulty is patients with either bilateral pleural effusions or shortness of breath, and those are the ones that have difficulty with the breath holds.
Excellent. Yeah, that's a really good point. So on all cardiac MRI scans, obviously if they're a critical patient, any difficulty being supine, that's probably making it difficult. So, but it's not just for the OS CMR scan, but it's for the entire cardiac MRI scan overall. And that's a very minor limitation of cardiac MRI overall, because the patient does have to lay supine for some time. And so, yeah, I do reiterate that if they do have fluid in their lungs, it will be difficult overall.
And what we've done on a few really, really sick patients, and that we know that they're not able, let's say, to quote unquote hyperventilate, but some of them, their heart rate and respiratory rate is already so high. What we do is we just run 2 minutes of for them it's free breathing, but their respiratory rate sometimes when they're really sick is already at 35, 38 or 42. So, and that is sort of mimicking a hyperventilation. So what we do is we just run the OS continuous acquisition for 2 minutes, and there's your hyperventilation right there. So that at least you can analyze those images.
That's great, Sylvie. Or Maggie, sorry. Okay, that was excellent. Thank you so much, Liz. And so while she's loading up our next case example, or Matthias, have any comments?
Yeah, I just wanted to, regarding the question from Calder with the oxygenation deficits. So a couple of years ago, we performed a study using BMOR in patients with obstructive sleep apnea. And many of those also had chronic obstructive lung disease, as you can imagine. And while some of them had actually were even on CPAP and also experienced difficulties during daily life, all of them were able to complete the protocol. So it is usually not a severe limitation, lung disease or otherwise difficulties. I mean, of course, severe, clinically very severe heart failure may become a limitation because people may not be able to even lay on the table for long enough. But as you saw probably yesterday in Katie's presentation, so even in patients with HFpEF, and we also have other populations with heart failure, it is definitely doable. So it's not a significant limitation. It's certainly not as much of a limitation because it's relatively short than a coronary angiography, for example, or any other test where you would have to lie flat.
Thanks, Matthias. And another comment from ThinkPad to everyone, how does the decline of the OxySense area, so the blue areas, so the reduced oxygenation, correlate with the myocardial ischemia evaluated by other methods such as hyperperfusion, so quantitative perfusion? That's a really good question. We didn't show quantitative perfusion in this case, but we could definitely show it, or perfusion data, CMR perfusion data in our next example. But it's quite heterogeneous. So we have found, in patients who have epicardial coronary disease, that there is a congruent relationship between reduced oxygenation using BMOR with that of perfusion with CMR. But another example that we're going to show right after this is, the microvascular dysfunction. And I'm going to share some slides to just put a little bit more clinical context on it, that we have seen a heterogeneous discongruent relationship. Areas of reduced oxygenation on BMOR may not always mean areas of hyperperfusion on CMR imaging. But yeah, that's a good question. Okay, excellent. So I'm going to be sharing some slides and to introduce the next case for Liz again, just to put in some clinical context here. And then I will also, bear with me, be sharing one of our collaborators right after this. Oops, sorry. Okay, so can everybody see that? Yes?
Yes.
Okay, great. Okay, so to introduce our next case, it's going to be an example of one of our INOCA patients. And I know we're throwing around all these clinical terms and not all of us will be aware of it. So I wanted to just do a quick 2-3 minute introduction to that case. So when we think of, myocardial ischemia, it's not always that straightforward of coronary stenosis, meaning like the epicardial coronary stenosis. We know that there's a lot of confounding complex factors that come into play, such as things like the myocardial bridging, inflammation, autoimmune disease, and as well as the coronary microvasculature. And for this next case, we're going to showcase an example of INOCA, which is ischemia with no obstructive coronary arteries. And essentially that is a dysfunction of your coronary vasomotor abilities. And together, those two are the coronary microvascular dysfunction and vascular spasm or coronary vasospasm. So when we talk about INOCA, so patients who have symptoms of chest pain, angina, but are found to have no obstructive coronary disease, we know that coronary vasomotor dysfunction is very common. So, in approximately 80% of those people, they will have some degree of microvascular angina or that of vasospastic angina. And so something is wrong with the small vessels of their heart. And we also know that it's not that straightforward. There are different mixed phenotypes. The traditional atherosclerotic disease that we know of stable plaque going into vulnerable plaque that Sheldon kind of alluded to before in your epicardial coronaries, that's just one component. But we now know that the microvascular of the heart plays a strong role, and then the two can actually have mixed patterns, which make it very hard and sometimes to evaluate. And so the microvasculature, if you don't know, if you can't visualize it, it's hard because all of our routine imaging modalities right now, what we do is we, with angiogram, we can look at these large blood vessels, but then deep down into the myocardium, there's a very complex, vast network of blood vessels, capillaries, etc., that range in different sizes and different functions, and they themselves are lined by different cells. So the endothelium that forms this intima, and then you have the vascular smooth muscle cells that form the media. And so it's a very complex network that we're only scratching the surface of. And believe it or not, this coronary microvasculature, I'm sure most of you actually are aware, actually make up the majority of the blood volume in the heart and the resistance in the heart. And it's actually responsible for the dynamic regulation of blood flow through the control of hormones and sympathetic tone. And when we talk about coronary microvascular dysfunction, it can be both a problem of abnormal structure. So they have, varied degrees of atherosclerosis. They can have thickening of the intima, and then they can or fibrosis. And then there's also can be a problem of capillary density. So it's very complex when we're looking at oxygenation, what degree of abnormal structures is coming into play. But there's also a degree of abnormal function. And we're only, researchers around the world are beginning to dive deeper into this area. Is it a problem of impaired vasodilation? Is it a problem of increased vasoconstriction? And the interplay between that of endothelial independent, endothelial dependent pathways into contributing to this microvascular dysfunction phenotype that we're trying to characterize. And then, the other black box is also the role of coronary vasospasm. And this is a very complex slide, but essentially, it's the other counterpart of INOCA. A large proportion of patients have INOCA, and a large proportion of those patients have coronary vasospasm. And it's hard to diagnose that. But what we believe is going on is it's likely an interplay between that of endothelial dysfunction, as well as your vascular smooth muscle cell hyperreactivity. And so what do we mean by that is, in an individual who's healthy, when you give them a stimulus like acetylcholine, that will stimulate nitric oxide to work on the vascular smooth muscle cells to relax and to increase blood flow. But in some patients who have endothelial dysfunction, acetylcholine does the opposite. It can directly stimulate the vascular smooth muscle cell to cause vasoconstriction, and that can precipitate a symptoms of microvascular spasm or a vasospastic angina. And so, is endothelial dysfunction a precursor to vasospasm? And we're only scratching the surface of how we can use BMOR to really further characterize this. And then with that, I'm going to now pass it on. Oh, there's a quick question from Layla. Is it possible to exclude the papillary muscles from the blood pool and assess the changes in signal intensities of the papillary muscles in this module? Well, that's a very excellent question. So as you know, there are anatomically correct ways to define volume and mass and function using cardiac MRI. And here, and as well as other strong researchers, we are a big proponent of including papillary muscle ventriculation as part of LV mass and not as part of the LV blood pool. And so this might be a question to Mitchel and the module of CBI. Could we do that? Could we exclude that papillary muscle to look at OS CMR, to look at the BMOR in there?
To exclude them or include them, but either ones are possible. You can activate the anatomically correct contouring in CBI42 and have the endo contour really be tightly around the blood pool where the trabecula and the pap muscles would be part of the myo. So that should be possible in the module.
Okay, great. Thanks, Mitchell. So I have the pleasure of including Dr. Odaime Casada, who will showcase what I was talking about in terms of, one of our INOCA preeclamptic patients. She's one of our international collaborators out of Cincinnati, Ohio in the US at the Christ Hospital. And she's the director of the Women's Heart Center in Cincinnati, in the Christ Hospital. And she's going to be introducing this case that Liz will then showcase on the TOM module. And so without further ado, Odaime, you can take it away.
Thank you so much, Judy, for introducing me. And I want to take this opportunity to also thank Judy for introducing me and allowing me to become a collaborator to Matthias, and then working very closely with Liz on how to use BMOR for this project. So I'll just give a quick introduction of what we're doing. But yeah, thank you for allowing me to be a collaborator. I'm very excited about our work and thinking about new other projects. So really quickly, this is the title of my NIH, National Institute of Health Career Development Award. So it's subclinical determinants of cardiovascular dysfunction in women with prior preeclampsia. And so just a quick background in the context of why we're doing this. So there is an important link between preeclampsia and cardiovascular disease. This has been something that's been recognized in the last decade more intensely. So we've learned that hypertensive disorders of pregnancy are actually now an independent risk factor for maternal cardiovascular mortality about 20 to 30 years after the index pregnancy. And just to put it into context, the more research we do, the more we learn about the hazard ratios, and it's starting to be similar to dyslipidemia, which we all recognize as a risk factor for cardiovascular disease. So just some numbers from big registries. So preeclampsia is related to a higher risk of hypertension. That's always been recognized, but now more and more is being related to coronary artery disease, stroke, and there is actually a greater relationship between the risk of heart disease and actually the severity of hypertensive disorders of pregnancy. And so here I just show you, because I know, we don't think about pregnancy a lot in this group probably, but when you're thinking about these hypertensive disorders of pregnancy, you go from gestational hypertension being the least severe to preeclampsia, then severe preeclampsia and eclampsia. And we're really trying to focus our study on the severe preeclamptic patients, which are the more severe ones. And the reality and the reason we're doing this study is because unfortunately, the mechanisms underlying the increased cardiovascular risk in women with a history of hypertensive disorder of pregnancy remains largely unknown. So with this in the background, so what is our hypothesis? So we believe that women, before they get pregnant, they probably have these metabolic traits, whether they know it or not. All, just of note, not always in every woman, but a lot of them, we find that they have these metabolic traits, which we believe contribute to inflammation and oxidative stress. We also think that these metabolic traits actually make women more at risk for hypertensive disorders of pregnancy, including gestational hypertension and preeclampsia. There's actually data that supports that. And then that is kind of a double hit model. They probably have some preconception metabolic traits that makes them more prone to hypertensive disorders of pregnancy. And then if they, of course, have both double hit, more inflammation and oxidative stress, there's a lot of good data from animal models that this happens when someone has specifically preeclampsia. That's where a lot of that data comes from. And so what we hypothesize as we were putting together this grant is that we believe that that actually leads to coronary microvascular dysfunction, which is why it ties nicely to Judy's introduction about microvascular dysfunction. So we were able to look at non-endothelial dependent coronary microvascular dysfunction. Now with BMOR, endothelial dependent coronary microvascular dysfunction and vasospasm, with the idea that this leads to then subclinical cardiac disease that we're able to essentially pick up in an MRI. So myocardial edema, diffuse fibrosis, scar we haven't really been seeing, but then adverse remodeling and myocardial dysfunction, which then leads to which leads to what we know is that elevated risk of cardiovascular disease later in life. So with that in mind, we came up with this 3-AIM grant, with AIM 2 really being the one where we're doing a lot of our collaboration and the work here at CRISE, which is to determine the extent to which measures of coronary microvascular dysfunction or biochemical stress are related to abnormalities in cardiac structure and function that persist in women with prior preeclampsia. And so I want to introduce a research case that we're doing. So this is a 41-year-old G2P2, so 2 pregnancies, 2 deliveries, no known cardiac history. Her first pregnancy was back in 2013 where she was diagnosed with gestational hypertension, delivered full term, so in the spectrum, the less severe of the disease. But then in her second pregnancy in 2016, she had severe preeclampsia preterm. So that's the worst of the worst, right before the worst being eclampsia, delivering at 31 weeks and 4 days. And so she met all the criteria of severe preeclampsia as noted below, and she was treated with blood pressure medications in hospital. And so her cardiac MRI, which Liz is going to share with you some of those images, occurred about 5 years after delivery. And one of the important exclusion criteria for this study is that patients are not on blood pressure medications at the time of a cardiac MRI. So we don't want chronic hypertension to muddy the waters. So these are really true healthy women, with the only exception is that they had preeclampsia. And so with that, if Liz is ready, I'll let you take over.
I sure am. Thank you so much. All right, so here we have the case that Dr. Quesada was just talking about. I've loaded it up already. So again, as in the last case, this is going to be what we're looking at in terms of our post-hyperventilation breath hold, BMOR value. And in nice, healthy, fully healthy, no medications, no history of any respiratory disease, cardiovascular disease, we see this whole myocardium being quite green throughout. Sorry, 1 second. And what we can see here and what we found in the preliminary analysis of this study with Dr. Quesada is that we are seeing in some ways some similar features to our ANOCA patients that we published the research letter on. So we see some areas of heterogeneity here, and I think this mid-slice particularly really highlights this quite well. Anything that's blue, as we mentioned before, any pixel that's blue is below our previously established cutoff values for being not fully healthy myocardium. And so we can see that here, and again, we can scroll through the entire cardiac cycle to really fully appreciate this across time, across pressures, across all states of the cardiac cycle. And we have it again in 2 slices. So I think for us, this is an ongoing study. It's still in I'd say fairly early stages. We've just run some preliminary internal and interim analysis, but these are the findings we found so far. So really highlighting the importance of microvascular dysfunction. And if you look at, you know, these polar maps, and previously what we were looking at is just the global response. There's no global difference between this and healthy, because if you look at the polar map, even if you really break this down into AHA segmentation only, there's maybe 2 full AHA segments here that are below our cutoff of healthy. Right. But when we start looking at this at a more granular level and we start talking about, okay, well, are there patches of heterogeneous myocardium that is not oxygenated really well? Can we be seeing this? And that's what we found. Matthias, I can see you're unmuted. You have your hand up. You're ready to rock.
No, I was just asking. So people may think, okay, these fluctuations over the cardiac cycle. So the question is, what we see here, that during these fluctuations, there are certain areas that basically fall below the threshold. What is your first impression of these fluctuations in healthy people? Do they never, or do they occasionally also fall below that? Or is this something that we, as soon as we can see some blue here, that, and I understand we're all early here, but we want to share this early experience. So what's your level of confidence that these fluctuations going to the blue are actually reflecting an abnormal vascular response, heterogeneity, as you beautifully showed in your paper?
Yeah, and that's a good point. I think that the ability to assess the entire cardiac cycle is very new to us. And as I mentioned, if I had done this before manually, it would have taken me the entire day. So the ability to assess this entire cardiac cycle is very new. So what I want to stress is that these normal values and the color coding for it is our end systolic values. And so I've stopped it here on the end systolic image, and that's really where these blue fluctuations come into play. In healthy people, we see blue fluctuations as we move through the cardiac cycle. And I think in the future, we're going to need to have phase specific or period of cardiac cycle specific values, just in terms of saying, okay, what's normal? How do normal people perfuse or oxygenate throughout the cardiac cycle? But in the end systolic phase, which I've shown here, I can say quite confidently that we know in healthy, we have 200-300 healthy people that we've analyzed now, and Kate Lindsay, who presented yesterday, is going to publish on the normal values of that. These are very specific to the end systolic phase. So it's a good point.
Yeah. And I too, to add to that, you know, the decision to analyze end systolic, end diastolic is one of a historical. It was when I was doing my doctoral studies, and I found that the myocardium obviously is thicker in end systole, but we all know the cardiac cycle, the myocardium perfuses at end diastole. But back then the technology wasn't available to, you know, pull out that signal intensity in diastole. And so we're only scratching the surface with this new module and prototype, and we're going to be able to analyze end diastolic phases and to see if there are blunted responses, or is there a more severe blunted response, particularly in those, you know, who have diastolic dysfunction, heart failure, coupled with that of microvascular dysfunction. So again, another call to collaborators out there, if you have an interest in diastology or cardiac phases, physiology, and when myocardium perfuse, then we definitely want to reach out to you or reach out to us. Okay, I see another question from Gelineau. She says, would it be interesting to use BMOR to evaluate the effect of cardiovascular rehab treatment or sport training? Problem is we don't have the sequence and protocol. You mean sequence and protocol for the cardiac rehab, or sequence and protocol for yourself, the BMOR? But yeah, so I think that is, you know, clinically a very useful question, because we do know that cardiac rehab after heart failure, cardiac rehab after acute coronary syndrome improves mortality and improves morbidity, improves your exercise function. And so it'd be really interesting to see that actual improvement based off of BMOR. And if that's a study that you're interested in, Gelineau, like reach out to us. We can easily adapt the BMOR sequence to your site. We've shown it live earlier in the day with Sylvie and Maggie, and as well as with Dr. Quesada, that we can do it remotely. You know, I never once stepped foot into Christ Hospital, and it was very easy for Liz and myself and our team to give her the protocol and to teach it, train it to her team over the course. And maybe Dr. Quesada or Daime, if you can speak up about how the process was like for you to collaborate with you remotely, because I never went to Ohio, but I will one day. But yeah, if you can just speak like, you know, kind of interject.
Of course.
What was your experience like?
Yeah, definitely. Thank you for, I think that's a great point. So yes, I live in Cincinnati, Ohio. I got to meet Judy, thankfully in person briefly before I left Cedars. That's where we got to meet. And then honestly, haven't gotten a chance to meet Liz or Dr. Matthias in person yet. But thank goodness for, you know, the world of Zoom now. So everything, you know, it really was working closely with Liz and my team on how to, you know, we pretty much did I believe we jumped on a few times just to learn the protocol. And I was lucky that my coordinator actually is a yoga teacher. So she was very good, already used to deep breathing exercises. So she felt pretty confident how to coach patients. So exactly what was said earlier, we do spend the time. So the way our protocol, I didn't want to go into too much detail, but it is a full day because we're doing vascular function testing on these women. We're doing lab draws, and then we take them to the MRI. And so as part of what we do at the beginning of the morning, we actually coach them. And that's where we first introduce them to the breathing maneuvers. Then they go to the scanner. They do it one more time, as was mentioned, before they go in the scanner, and then they're in. And they actually, the feedback I've gotten from Liz is overall the data quality was actually very good very early on. So I just want to encourage anyone that wants to collaborate. We were getting very high quality data, I would say within, you know, the first few patients. We did have Liz actually live through camera on our first 3 cases, I want to say. And then she was like, okay, you guys are off to the races. And ever since then, she looks at the data afterwards and keeps saying everything looks good. So I think it was very smooth.
And do we also want to, or Liz, you can, or I want to say that, you know, as our, you know, we are experts in the BMOR and the OS CMR sequence on the McGill side, but we also meet with your team and your research team to make sense of the data. And so we have regular research meetings with Odaime and her team. And so it's not like you're into the wilderness having to interpret all this yourself.
Yes.
We work collaboratively with you as part of your team to make sure that you're supported from the research side.
Exactly. Yes, we do have monthly meetings. We share data from, you know, analysis, like interim analysis on both sides. So yeah, we're working very closely together. So it's a wonderful collaboration. Thank you, Judy. And, you know, we're also thinking of other ways that we can work together. You know, whether we could use invasive testing, which we do a lot of at Christ Hospital for microvascular dysfunction, and comparing that to these innovative measures.
Yeah, I think one of the points, and maybe we haven't mentioned this, is that our sequence is a modified SSFP. We don't have a sequence that's licensed, that you have to get a WIP for, that you have to go through a vendor. It's a modified, we change a couple of parameters. And so we are vendor agnostic. The first image that, or the first case that I showed, that was the CAD case, that was a GE case. The second one was a Siemens case, and it's not complicated. We like to keep control, mostly because 1, I'm a control freak, but 2 is because the problem that people have with this is the breathing maneuver, and the techs see the hyperventilation images and they're like, these are terrible, and people get a little bit nervous because it's not a way that anyone scanned before. And so, like Dr. Quesada was saying, after 2-3 scans, people are like, okay, Liz said this was fine, so it's fine, right? And then they start seeing the images and they see the analysis, and people get a little bit more comfortable with it. But this is not something that you need to go through a vendor, or you need to go through anything to get approval for this. This is a modified SSFP, and we've kept it that way on purpose and really tried to stay true to that. Like Matthias also always says, we're not here to make money off of this. We want everybody to be able to use this. But what we need to do is make sure that when people start using it, they're using it correctly, so that the data is good and the methodology stays true to what we're trying to induce, which is the vasoconstriction, vasodilation. We need the breathing maneuver to be good so that we can see those changes and see the changes in signal intensity. I don't know if Judy, Matthias, you have something to add to that.
Yeah, no, before I let Judy finish off, I want to say I agree with you, Liz. This is really about working together to develop, validate, and have progress with a method that I think truly is one of the most exciting things that happen these days in cardiac MR and in cardiology for that matter. It allows us to use a physiological marker, which is the oxygenation, instead of a surrogate marker such as perfusion or tracer accumulation and such. Use this physiologic marker in a very safe procedure that is just consists of different breathing patterns, with a method that doesn't use any radiation or contrast agents for that matter. And we have to, of course, be very aware that we are all still learning. This is not that this is ready to go and everybody can use it in their patients. No, we need the help of each other. We need to validate, so we need to be critical. We need to make sure that we understand where may be limitations of this technology. And we have to be very open for that. I'm very grateful for Circle for providing the back end of that, because drawing all these contours, we would take years of drawing before we would get to a point where we get and I also have to say here that that while I'm involved in Circle, I'm also grateful that Circle agreed to go on that journey, because let's face it, a company has to somehow think of how to pay the bills and make money. And this is yet unknown how this will end. However, having said that, to me, this meeting was extremely exciting, because I can, probably everybody else here can sense that this is real and this is important, and this has not only potential, but also has reached a stage of validation and practicability that there is no way back. There will be an application for that. There will probably lots of clinical applications for that. We just have to figure out together how we can best demonstrate the validity of the results and the practicability, and of course also the safety. But to me, I'm extremely excited about this, and the participation at this conference here, and also the feedback I already got from people who are thrilled about this technology and want to get started. This is, to me, very, very exciting. And so I encourage everybody to A, spread the word, and B, think about how they could contribute to that, how we can move this forward, eventually leading to technology that is safe, easy, cost efficient, and especially has a positive impact on patient outcomes. So with that, I want to also thank Judy and Liz for the wonderful sharing today. And back to you, Judy and Liz.
Yes, so I do see that question from Jalom, but we can address that maybe now too. So she asked how to use this breathing maneuver in an animal experiment. Yeah. You just mentioned it in the validated pigs, and Matthias can talk about it.
So this is actually much easier than you think, because when we did that, and this was mainly work by Dominic Günsch and Katie Fisher with the help of Julie Lebel at the Montreal Institute, and also work in Calgary. So these pigs of course are intubated and ventilated, and you basically just control their breathing, and you simulate normal breathing, and then you simulate hyperventilation by increasing the volume and the respiratory rate, and then you just switch off the ventilation at an expiratory level. With a safe period of, let's say, 1 or 2 minutes, there will be no meaningful decrease of oxygen. So there is no risk. Also, if people do these breathing maneuvers, as I mentioned before. So that's actually a very controlled environment that allowed us also at that time to in parallel acquire data on coronary flow, and also on ventricular function, etc. And most of the data have already been published. I posted one of the papers here in the chat. There are other papers, and one paper is still in the pipeline that specifically addresses coronary flow. But some of the flow data already mentioned there. So doing that in animals is actually, aside from all the complexity of animal research in general, the MR protocol itself with the breathing is actually very easy.
Great, thank you so much, Matthias. And then we're almost near the end, and I'm going to do a brief high-level summary before we open to our open discussion. And then Liz Kay is our overall coordinator on this, and if she can post her email for those international collaborators who are interested, please, you can email her and you can start the ball rolling that way. Okay, so I'm just going to quickly share slides, and then I'm going to let Liz take over to briefly do our open discussion. Although it's been phenomenal. You guys have been very interactive and been actively actively sharing your comments already. So that's why I don't think we need too much of a. So just an overall high level summary of what you've seen in the last 2 days, and just some takeaway points to trigger your further questions and further collaborations that you have with your team at your end at your center. And so we've talked about in the last 2 days, essentially this different paradigm that we're establishing for ischemic heart disease, and we're showcasing what the role of OSCMR when coupled with breathing maneuvers can be for that paradigm. And yesterday, Kate talked about the subclinical utility of OSCMR and how different modifiable as well as non-modifiable risk factors could potentially alter that BMOR sequence. And she talked about how age and sex and BSA, but we've only scratching the surface, and we want to know further what traditional risk factors, how female-specific risk factors, and then social, environmental, and genetics, how they could differentially impact that OSCMR. And then yesterday, Matthias shared a lot of the groundwork in the epicardial coronary artery disease and how that laid the foundation down for our OSCMR. And today, Liz Hillier showcased one of the INOCA patients in collaboration with Dr. Odame Quesada about, microvascular dysfunction, potentially vasomotor dysfunction. So all of that, again, we're only scratching the surface. And a lot of the proportion of patients do have non-obstructive coronary artery disease, specifically in the female population. And yeah, so for any of the physiologists or people who are experts in this area, when we talk about vasomotor dysfunction, we want to work with you. We want to better understand the different pathways, that define microvascular dysfunction and how that differentially impacts OSCMR, what that signal truly means when we look at the heterogeneity. And so we're scratching our heads when we see this, but if you are an expert in this area, do reach out to us because we want to hear from you. And then we briefly only mentioned one of the collaborative studies using BMOR and OSCMR in the emergency setting, and how we're moving away from essentially needle-free approach. We do not need to use adenosine, do not use gadolinium, and so there's a huge potential in how to use OSCMR or how to apply OSCMR in the acute setting, both in the acute coronary syndrome, so acute plaque rupture, so traditional atherosclerotic disease, but also in the MINOCA population and myocardial infarction with non-obstructive disease, which is emerging, and we're only understanding that more. And so we have yet to apply OSCMR and BMOR in this population, but if there are again, researchers out there who are interested in, SCAD, myocarditis, Takotsubo, et cetera, reach out to us because we want to work with you to better understand that phenotype as well. And then again, nothing has to be said more about how in the advanced stage of end-stage disease of ischemic heart disease, you have heart failure. And then Katie Fisher demonstrated eloquently all the potential utility of that. But in reality, it's not 1D linear like I just showcased there. It's probably more of a Venn diagram. There's mixed phenotypes. There's huge overlap between the stable, acute, and the advanced stage. And so it makes for a very complex, heterogeneous pattern of what we're trying to characterize. And we truly believe at the heart of that OSCMR and the OSCMR can be used as a very important tool. And then yesterday, including today, we showcase all the different things that we're working on. Maya talked about the breath hold response, heart rate response, and how that's going to be that can be automatically captured seamlessly in the breathing maneuvers. Liz showcased, as well as Mitchell, all the different novel biomarkers that we have. And again, we want to hear from you what other biomarkers you have at your site. We just talked about the global BMOR and the regional BMOR. And then showcasing with the TOM module, the circle module, the benefit of automation and batch analysis, how it's more accurate, it's also more efficient. And so we're streamlining that for you with our industry partners. And then finally, yesterday, Mitchell only briefly mentioned about Cardiome, which is an advanced algorithm for machine learning to essentially process big data, millions of data points, both raw data, images, both clinical variables, you know, genetic work, blood work, all of that. We're only scratching the surface yesterday when he talked about it, but cardiome is really a strength that we have here because it's going to be our ultimate tool to characterize all these different heterogeneous phenotypes. And with that, I'll leave it open discussion, you know, our future directions of where we want to go from here. You know, we've yet to define the clinical severity. What does a blunted response of 5%, you know, -5%, -20% truly mean in the clinical spectrum of an individual who has heart failure or ischemic heart disease? We've yet to establish the prognosis like we do with the robust data we have with CT or SPECT. But, you know, it's going to be years in the future, but this is something that we want to establish now with our collaborations. If you're interested, and then ultimately how we want to determine the clinical impact of using an OSCMR and how that impacts clinical management. So we talked a lot about science, and I'm just putting it into a clinical perspective for you because, you know, it's all about knowledge translation and our partners internationally. And so with that, I know we're running out of time, but Liz can finish it off, and that's about it.
Thanks, Judy. Yeah, I just want to open up the floor. I mean, we don't have as much time for open discussion, but I think we've had a lot of discussion along the way, and that's been really encouraging. So does anyone have any last minute questions or thoughts? Matthias does.
No, and I just wanted to add to what Judy beautifully summarized, that I think the way we should look at it is not necessarily seeing what will OS CMR show, but the consideration should be, how does microvascular function affect my research interest? How is microvascular function a candidate for an important component here? Because we do not need to further validate the fact that breathing maneuver has an impact on vascular function. This is well known since decades, so this is old. What is new is that we can track that with oxygenation sensitive MR. And while the method of oxygenation sensitive MR mostly relies on the Bold effect, of course there are some confounders that I only peripherally mentioned. So blood volume and blood flow are small confounders, but the good point is, the good news here is that they work in parallel with the Bold effect. So all of them contributing to the signal intensity changes that we observe. So this is not a limitation or a confounder, it's just supporting the fact that we can track vascular function using this technology. And so what I would like to get everybody here think about is, okay, what are aspects of microvascular function and the added problem of macrovascular dysfunction? So because if we talk about coronary artery disease, we tend to think of the coronary artery stenosis and the induced blockage. That's fine, that's interesting and important, but often this is associated with a more global peripheral microvascular disease, and how these play with each other, how they add to each other, that is an important area. And with this tool, we have the opportunity to see both. At the same time, we can see the global abnormality, and we can see regional differentiation and differences. So we can look at microvascular dysfunction and macrovascular dysfunction. So that offers a huge opportunity to assess, as shown in an example from Katie in heart failure, and as being studied now by Odaime in certain subpopulations, and in Judy, by Judy with her interest in INOCA, and Liz with your interest in the homogeneity in these people, but also, and you have not talked about that a lot, how this also affects actually brain and cognitive function. So even those of you who are interested in more the cerebrovascular level, so this is also an opportunity to use the same technology there. So I think this is a fascinating area, and to me, I'm very thrilled about this conference, because to see so much activity and such an interest that will trigger meaningful research, and we can move the field forward. So I want to cordially thank everybody for their participation.
Yeah, and see that email at the very end there in their group chat, like do write it down. Again, if you would like to reach out and collaborate, start the ball rolling, just email our Liz K and then everything will get started. Okay, any final remarks, Matthias or Liz or anyone? We're at the noon hour, so right on time.
Liz, anything you want to add here?
Oh, we do have one question. We have one question.
Oh, there we go. Perfect. I wonder whether hyperventilation and hold could induce arrhythmia among some vulnerable patients and whether the existing arrhythmia could influence the detected oxygenation sensitive data. Matthias or Judy, do you want to comment on that?
I've never seen induced arrhythmia.
Neither.
In fact, the rhythm is always very stable. So, Maya, have you seen arrhythmia? You looked at heart rate and.
So actually having arrhythmia was an exclusion criteria for my study because
yeah, pre-existing, but during the maneuver, have you ever seen?
Oh no, no, none of the patients got any arrhythmia or any other complications during breathing maneuver. So yeah, even those patients that had in their Holter, they had some PVCs or some like they were disposable, like they were vulnerable maybe to arrhythmia, but no, they didn't show anything during hyperventilation.
Great. Well, I just want to thank everybody for caring about this, showing up to this symposium, giving up your Saturday. We'll let you go. I think we've done pretty well both days on staying on time. Proud of us. But thanks for coming and engaging with us. I really, to echo what Matthias said, seeing the participation, seeing people really engage with us and ask questions is really good to see and helps us communicate what we're doing and what we're really excited about outside of the four walls of the hostel in Montreal. So thanks everybody. Reach out to any of us if you have questions and we're more than happy to meet with you, email you, whatever you want.
Maybe we can see some of each other and discuss at the SCMR. But other than that, we will certainly have a third of these symposiums next year, where we can hopefully present new data and highlight some more preclinical applications. So thank you, everybody, cordially, and be well, be safe, and stay tuned. And otherwise, best wishes.
Thank you, everyone. Have a great afternoon.
Bye.